we'll be studying today a bit about the heart sounds. The heart sounds are detected over anterior chest wall by two methods basically, which is auscultation and phonocardiography. Auscultation is basically listening via stethoscope or hearing the sounds directly, and phonocardiography is a sound recording device which plots the sound values on the piece of paper. Now, a typical stethoscope contains two chest pieces for auscultation of the heart. The concave belled chest piece, meant to be applied lightly to the skin, it accentuates low frequency sounds. Conversely, the flat diaphragm chest piece should be pressed firmly against the skin to eliminate two low frequencies and therefore accentuate high frequency sounds and murmurs. Some modern stethoscopes incorporate both the bell and the diaphragm functions into a single chest piece. In these models, placing the piece lightly on the skin brings out the low frequency sounds, while firm pressure accentuates or elaborates the high frequency ones. These sounds are best heard at four certain areas of the body. One is the aortic area, which is located at second right costal space, the pulmonary area, which is located at the second left intercostal space, the tricuspid area, which is located at the lower part of the sternum towards the right side, the mitral area, which is located at the fifth left intercostal space crossing the mid-clavicular line, which is 9 cm line or 2.5 to 3 inches from the sternum. Now, an easy way to memorize them is a mnemonic, like all people take medicine and all the areas are covered. Now, there are two basic heart sounds produced are S1 and S2. There can be an S3 and S4, but mostly S3 and S4 can be pathological or, in easy words, related to heart diseases. S1 is produced by the closure of mitral and tricuspid valve in early systole and is loudest near the apex of the heart, which is located on the body surface as the mid-clavicular line in the fifth intercostal space. It is the most inferior, anterior and lateral part of the heart which lies in situ. It is high frequency sound best heard with diaphragm of the stethoscope, although mitral closure usually precedes tricuspid closure, and they are separated by only about 0.01 seconds, such that the human ear appreciates only one single sound because the timing is very small in between these two. The exception occurs in patients with right bundle branch block, in whom these components may be audibly split because the delayed closure of the tricuspid valve. Three factors are there which determine the intensity of S1. The distance which is separating the leaflets of the open valve at the onset of the ventricular contraction, the mobility of the leaflets, which may be normal or rigid because of stenosis, and the rate of rise of ventricular pressure. Now let's hear these sounds. The first one is S1 and the second one is S2. You can appreciate the difference between the sharpness of these two sounds. Now the second heart sound. The second heart sound results from the closure of the aortic and the pulmonic valves, and therefore has aortic and pulmonic component, or in short can be said as A2 and P2. Unlike S1, which is usually heard as a single sound, the component of S2 vary with the respiratory cycle. They are normally fused as one sound during expiration but become audibly separated during inspiration, a situation termed normal or physiologic splitting. And one explanation for this normal splitting of S2 is that there can be expansion of the chest during inspiration, which causes the intrathoracic pressure to become more negative. The negative pressure transiently increases the capacitance, which reduces the impedance of the intrathoracic pulmonary vessels. As a result, there is temporary delay in the diastolic back pressure of the pulmonary artery responsible for the closure of the pulmonary valve. Thus, P2 or pulmonic component is delayed. That is, it occurs later during inspiration than during expiration. Inspiration has opposite effect on aortic component of second heart sound, or A2. Because the capacity of the intrathoracic pulmonary veins is increased by the negative pressure generated by the inspiration, the venous return to the left atrium and the ventricle temporarily decreases. Reduced filling of left ventricle causes a reduced stroke volume during the next systolic contraction and therefore shortens the time required for the left ventricular emptying. Therefore, the aortic valve closure or the aortic component occurs slightly earlier in inspiration than during expiration. The combination of an earlier A2 and delayed P2 during inspiration causes audible separation of the two components of the second heart sound. Since these components are high frequency sounds, they are best heard with the diaphragm of the stethoscope, and splitting of S2 is usually most easily appreciated near the second left intercostal space next to the sternum, which is the pulmonic area. So let's say the split of the second heart sound during inspiration. Now the S2 duration is 0.11 seconds and S1 is about 0.14 seconds. Is that semilunar valve are two reasons for shorter S2 is that they are more tight than AV valves, so they vibrate for shorter time than the atrioventricular valves. The S2 has a higher frequency than S1 for two reasons: the tautness of the semilunar valves than the AV valves, the greater elastic coefficient of taut artery walls that provide the principal vibrating chambers for the S2. Widened splitting of S2 refers to an increase in the time interval between A2 and P2, or the aortic or the pulmonary component of the S2 sound, such that the two components are audibly separated even during expiration and become more widely separated on inspiration. This pattern is usually the result of delayed closure of the pulmonic valve, which occurs in the right bundle branch block and pulmonic valve stenosis. Now, the fixed splitting of S2 is abnormally widened interval between A2 and P2 that persists unchanged through the respiratory cycle. The most common abnormality that causes fixed splitting of S2 is atrial septal defect. So let's say and recognize this pathological splitting of S2 sound. Remember, the initial one was a physiological splitting. This one is the pathological splitting happening due to an anomaly. Now, an abnormal sound is called a abnormal heart sound is called a murmur and is usually due to faulty valve action. For example, if a valve fails to close tightly, the blood leaks back, a murmur is heard. Another condition giving rise to an abnormal sound is narrowing or stenosis of a valve opening. The many conditions that can cause abnormal heart sounds include congenital birth defects, diseases, and physiological variations. An abnormal sound caused by any structural change in the heart or the vessels connected with the heart is called an organic murmur. Certain normal sounds heard with the heart is certain normal sounds can be heard while the heart is working can also be described as murmurs, such as sounds heard during rapid filling of the ventricles. To differentiate these from the abnormal sounds, they are more properly called functional murmurs. These murmurs are sound heard with associated feeling of vibration of sound known as thrill and can be radiating to the different body parts. These murmurs are graded according to their intensity, such as grades of murmurs of intensity like grade 1, 2, and 3. Now, grade 1 is heard by an expert in optimal condition, grade 2 murmur is heard by a non-expert in optimal condition, and grade 3 is heard with no thrill. Here it is worthy to mention that a thrill is a vibratory sensation felt on the skin overlying an area of turbulence and indicates a loud heart murmur usually caused by an incompetent heart valve. Now, grade 4 murmurs are loud murmur and they have a palpable thrill, or in easy words, you can feel the thrill on palpation. Now, the grade 5 murmur is a very loud murmur often heard over a wide area with a palpable thrill. And grade 6 murmurs are extremely loud, they can be heard without a stethoscope. Now, the radiation of murmurs is a very important part. While the murmurs are usually more intense at one specific listening position, they often radiate to the other listening position of the areas of the body. For example, the murmur of aortic stenosis frequently radiates to the carotid arteries, and the murmur of the mitral regurgitation radiates to the left axillary region. It is often difficult to distinguish if one murmur is radiating to the multiple sites or if there is multiple murmurs present from many different causes from the same area, or the dynamic auscultation and echocardiography are helpful in determining the exact lesion present. Not single part can be distinguished very easily. Now, there can be many causes for altered intensity of the first heart sound, which may be that as sound S1 may be accentuated, can be due to shortened PR interval, mild mitral stenosis, or high cardiac output states, or tachycardia, for example, during exercise or in the cases of anemia. Then they can be diminished S1 on the first heart sound, which may be due to the lengthened PR interval, the first degree AV nodal block, mitral regurgitation, severe mitral stenosis, or stiff left ventricle, which may be due to systemic hypertension. The third heart sound, which is also known as S3 or also known as ventricular gallop, occurs just when S2 or after S2 when the mitral valve opens and allowing the passive filling of the left ventricle. The S3 sound is actually produced by the large amount of blood striking a very compliant left ventricle. Here is a bit of clinical related to it that an S3 heart sound is produced during passive ventricular filling. If the left ventricle is not overly compliant, as in most adults, the S3 will not be loud enough to be auscultated. The S3 can be normal finding in children, pregnant females, and well-trained athletes. However, an S4 sound is almost always abnormal. Now, the clinical related to it is that S3 heart sound is often a sign of systolic heart failure. However, it may sometimes be a normal finding in other patients or people. S3 can be an important sign of systolic heart failure because in this setting, the myocardium is usually overly compliant, resulting in dilated left ventricle. S3 is a low-pitch sound, and this is helpful in distinguishing an S3 from a split S2, which is actually high-pitched. An S3 heart sound should disappear when the diaphragm or the stethoscope is used and should be present while using the bell. The opposite is true for the split S2. Also, the S3 sound is heard best at the cardiac apex, whereas a split S2 is best heard at the pulmonic listening position, which is the left upper sternal border. To best hear S3, the patient should be in left lateral decubitus position. Now, the fourth heart sound, or S4, is also known as the atrial gallop. It occurs just before S1 when the atria contract to forcefully push the blood into the left ventricle. If the left ventricle is non-compliant and atrial contraction forces the blood through the atrioventricular valves, the NS4 is produced by the blood striking the left ventricle. Now, the clinical pearl that is associated with this part is that the S4 heart sound occurs during left ventricular filling when atria actually contracts and pushes and forces the blood into the non-compliant left ventricle, and it is the striking of the blood that creates that sound. Compliance is defined as inverse of stiffness. A more compliant left ventricle will allow for a larger change in the volume of any given change in pressure. In ventricular hypertrophy, the ventricular compliance is decreased, that is, the ventricle is stiffer. Because of the thickness of the ventricular wall increases, therefore ventricular end diastolic pressure is higher at any given end diastolic volume. Therefore, any condition that creates a non-compliant left ventricle will produce an S4, whereas any condition that creates an overly compliant left ventricle will produce an S3 heart sound. An S4 heart sound can be an important sign of diastolic heart failure or active ischemia, and is rarely a normal finding. Diastolic heart failure frequently results from severe left ventricular hypertrophy or LVH, resulting in impaired relaxation or compliance of the left ventricle. In this setting, an S4 is often heard. Also, if an individual is actively having myocardial ischemia, adequate adenosine diphosphate cannot be synthesized to allow for the release of the myosin from the actin. Therefore, the myocardium is not able to relax and an S4 will be present. It is important to note that if a patient is in atrial fibrillation, the atria are not contracting, and it is impossible to have an S4 heart sound. The clinical pearl related to it is that they may often be a single diastolic heart failure, and it is rarely a normal finding in S3, but S4 will always be heard in a sign of the diastolic heart failure. Now let's study about systolic heart murmurs. First, we will go through the mid-systolic murmurs, which are also known as the systolic ejection murmurs, or SEM. They include murmurs of the aortic stenosis, pulmonic stenosis, hypertrophic obstructive cardiomyopathy, and atrial septal defects. The mid-systolic murmur begins just after S1 heart sound and terminates just before the P2 heart sound. Thus, the S1 and S2 will be distinctly audible. The term mid-systolic is preferred to SEM because many lesions that produce mid-systolic murmurs are unrelated to systolic ejection. Now we will go through one anomalies one by one. That is, first is the aortic stenosis, which is a classic murmur and is a high-pitched crescendo, decrescendo, diamond-shaped murmur. Now, a crescendo is used for gradually getting louder and is of low pitch, rumbling, and character sound, and a decrescendo or diminuendo is used for gradually getting softer. So, the mid-systolic murmur is located at the aortic listening position and radiating towards the neck. So, let's hear and see how it makes sound while listening. Now, the radiation of the aortic stenosis murmur is often mistaken for a carotid bruit. Now, the carotid bruit is a vascular sound usually heard with the stethoscope over the carotid artery because of the turbulent non-laminar blood flow through the stenotic area. The carotid bruit may point to an underlying arterial occlusive pathology that can lead to a stroke. Now, aortic stenosis murmur is also known to radiate to the cardiac apex on occasion, making it difficult to distinguish if mitral regurgitation is also present. This radiation of aortic stenosis murmur to apex is known as Galivardian dissociation. It is described as a dissociation between the noisy and the musical components of the systolic murmur heard in the aortic stenosis. Determining if coexisting mitral regurgitation is the cause of the apical murmur in the patient with aortic stenosis requires the dynamic auscultation and echocardiography. The intensity of the murmur of the aortic stenosis is not a good indicator as the severity of the disease worsens. So, as the aortic stenosis worsens, the left ventricle begins to fill and the ejection fraction declines to the point where sufficient force to create turbulent blood flow is no longer produced. It results in a decrease in the intensity of the murmur. While the intensity of the murmur may not be accurate determinant of the aortic stenosis severity, the shape of the murmur can be helpful. Now, as aortic stenosis worsens, it takes longer for the blood to eject through the valve. So the peak of the crescendo-decrescendo murmur moves towards late in systole. Therefore, mild aortic stenosis would have a murmur that peaks early in the systole, whereas a murmur of the severe aortic stenosis would peak later. Now remember from the heart sounds that the delay in the aortic closure can cause a paradoxical splitting S2 heart sound, and as the aortic valve becomes more heavily calcified, the intensity of the S2 heart sound declines. Also, in the patients with the bicuspid aortic valve, an ejection click may be heard just before the murmur begins. So, in pulmonic stenosis, the murmur of pulmonic stenosis is very similar to that of the aortic stenosis. It is a mid-systolic, high-pitched crescendo-decrescendo murmur heard best at the pulmonic listening position and radiating slightly toward the neck. However, the murmur of the pulmonic stenosis does not radiate as widely as that of aortic stenosis. The murmur of the pulmonic stenosis peak early if the disease is mild and peak later as the disease progresses. Also, the murmur demonstrates increased intensity during inspiration due to increased venous return to the heart, resulting in greater flow across pulmonic valve. So let's hear this murmur, how it is heard on auscultation. compared with the murmur of the aortic stenosis, this murmur extends up to the aortic component of S2 heart sound, and the murmur of the pulmonic stenosis extends through this aortic component sound up to the pulmonic component of the S2 heart sound. Severe pulmonic stenosis results in decreased mobility of the pulmonic valve leaflets, thus a softer pulmonic component of S2 sound. Also, as the pulmonic stenosis worsens, as the closure of the pulmonic valve is delayed, more time is required to eject the blood through the stenotic valve. This results in a widely split S2 heart sound that is still exhibiting inspiratory delay. So do please note that murmur of atrial septal defect discussed is also a mid-systolic, however, it has a fixed split S2. Now, in atrial septal defect, the murmur produced by an atrial septal defect is due to an increased flow through the pulmonic valve, making it remarkably similar to the pulmonic stenosis. The difference lies in the intensity and splitting pattern of S2 heart sound, and the intensity of S2 should remain unchanged and may in fact be accentuated if pulmonary hypertension develops. The S2 is fixed split in patient with atrial septal defect, so let's hear the auscultatory sound of this anomaly. This differs from the widened split S2 seen in the severe pulmonic stenosis. Also, the murmur of an atrial septal defect does not increase in intensity with inspiration. Now, in hypertrophic obstructive cardiomyopathy or HOCM, the murmur is important to detect due to its clinical implications. The particular murmur is high-pitched crescendo, recrescendo, mid-systolic murmur, heard best at the lower left sternal border. So let's hear how it is heard on auscultation. The murmur of hypertrophic obstructive cardiomyopathy does not radiate to the carotids like that of aortic stenosis. The important auscultatory feature of HOCM that distinguish it from aortic stenosis relate to the dynamic auscultation, which we will be discussing just in a while. Now the holosystolic murmurs, which are also known as pansystolic, include the murmurs of the mitral regurgitation, tricuspid regurgitation, ventricular septal defects, etc. Because the intensity of these murmurs is high immediately after the onset of S1 and extends up to just before the S2, or in other words, the intensity is high throughout the systole. The S1 and S2 sounds are often overwhelmed by the murmur and may be difficult to hear. Its sounds is such that because of the result of the retrograde flow of the high pressure chamber into the low pressure chamber, the retrograde blood flow is the flow of the fluid in direction opposite to that considered normal. Like blood should pass from high pressure chamber to low pressure, but it is going opposite way over here. Now in mitral regurgitation, the murmur is described as high-pitched, blowing holosystolic murmur, which is best heard at the apex, although the direction of the radiation of the murmur depends on the nature of the mitral valve disease. It usually radiates to the axilla, so let's hear how it is heard on auscultation. Now the intensity of this murmur does not increase with inspiration, helping to distinguish it from the murmur of the tricuspid regurgitation. Mitral regurgitation is best heard at the left fifth mid-clavicular line with possible radiation to the left axilla. It is commonly associated with infective endocarditis and rheumatic heart disease, congenital anomalies, and inferior wall myocardial infarction. Now, in tricuspid regurgitation, the murmur is similar to that of mitral regurgitation in that it is high-pitched and holosystolic. However, it is best heard at the left lower sternal border and radiates to the right lower sternal border. The intensity significantly increases with inspiration, helping to distinguish it from the mitral regurgitation. So let's hear how it is heard on auscultation. Now, the inspiratory enhancement of the tricuspid regurgitation murmur is called the Caravello sign. Now, the Caravello sign is the murmur of the tricuspid valve which gets louder with deep inspiration. This part, as well as the location of the murmur, helps to distinguish tricuspid regurgitation from mitral regurgitation. Now, let's talk a bit about ventricular septal defect. Its murmur produces yet another holosystolic murmur, and the blood abnormally flows from the left ventricle, which is high pressure, to the right ventricle, which is low pressure, thereby creating a turbulent blood flow, and the holosystolic murmur is heard best at the Erb's point. Now, the Erb's point is the nerve point of the neck. It is sited at the upper trunk of the brachial plexus, located 2 to 3 centimeters above the clavicle. It is located at third intercostal space to the left, about 2 transverse fingers parasternally. The smaller ventricular septal defect, the louder will be the murmur. So let's see how it is heard on the auscultation. Now, there are some murmurs which happen in the late systole. These are the murmurs of the mitral and tricuspid valve prolapse and is only significant later systolic murmur. Tricuspid valve prolapse is relatively rare and usually not a clinical significant part. But the mitral valve prolapse produces a mid-systolic click, typically followed by a uniform high-pitched murmur. The murmur is actually due to mitral regurgitation that accompanies the mitral valve prolapse. Thus, it is heard best at the cardiac apex. Also, the length of the murmur signifies the time period over which the blood is leaking back into the left atrium. It is also known as regurgitation, and it results from sudden tensing of the mitral valve apparatus as the leaflets prolapse into the left atrium in systole. Now, the mitral valve prolapse will respond to dynamic auscultation. So, let's hear how it is heard upon auscultation. Now, there are diastolic murmurs which include the aortic and pulmonic regurgitation. It can be early diastolic and mitral or tricuspid stenosis, and mid to late diastolic as well. So, the tricuspid stenosis is usually very rare. For early diastolic murmurs, such as aortic regurgitation, the murmur is soft, high-pitched, and happens in early diastole. It is decrescendo murmur, usually heard best at the third intercostal space on the left Erb's point at the end expiration, with the patient sitting up and leaning forward. However, if the aortic regurgitation is due to aortic root disease, the murmur will be heard best at the right upper sternal border. It is not the Erb's point, as the aortic regurg worsens in severity. The pressure between the left ventricle and the aorta equalizes much faster, and the murmur becomes significantly shorter. In patients with aortic regurg, an early diastolic rumble may also be heard at the apex due to regurgitation jet striking anterior leaflets of the mitral valve and causing it to vibrate. The murmur is termed the Austin Flint murmur. So let's see how it is heard on auscultation. In addition to these murmurs, a systolic ejection murmur may be present in the patient with severe aortic regurgitation at the right upper sternal border, simply due to the large stroke volume passing through the aortic valve with each systolic contraction of the left ventricle. Now, in pulmonic regurgitation produces a murmur that is often indistinguishable from that of the aortic regurgitation. The pulmonic regurgitation produces a soft, high-pitched, early diastolic decrescendo murmur, heard best at the pulmonic listening position. Also to be remembered here is the point that a crescendo is used for gradually getting louder and a decrescendo or diminuendo is used for gradually getting softer. The murmur of the pulmonic regurgitation increases in intensity during inspiration, unlike that of the aortic regurgitation. So the murmur of pulmonary regurgitation is classically referred to as Graham-Steele murmur, which is soft blowing decrescendo early diastolic murmur of the pulmonary incompetence caused by the pulmonary hypertension. It leads to the accentuated second sound that mimics the murmur of the aortic insufficiency and is best heard at the left sternal edge, second intercostal space with full inspiration. So let's hear how it is heard on the auscultation. Now let's study about mid to late diastolic murmurs. Now one of the murmur of this type is a mitral stenosis, which is a uniquely shaped low-pitched diastolic murmur best heard at the cardiac apex. The opening of the mitral valve produces an opening snap due to the high left atrial pressure, immediately followed by a decrescendo murmur as the blood flows passively from the left atrium to left ventricle through the stenosed mitral valve, creating a turbulent sound. Immediately before the S1 sound, active left ventricular filling occurs when left atrium contracts and forces more blood through the stenosed mitral valve, creating a late diastolic crescendo murmur. So let's hear how it is heard on auscultation. In the presence of the atrial fibrillation, the active left ventricular filling phase does not take place and the latter part of the mitral stenosis murmur disappears. Now, as the mitral stenosis worsens, the left atrial pressure increases, forcing the mitral valve to open earlier in diastole. Thus, in severe mitral stenosis, the opening snap occurs earlier, as does the initial decrescendo part of the murmur. The opening snap and the murmur of the mitral stenosis also respond to dynamic auscultation. Now, there are particular continuous murmurs such as patent ductus arteriosus or PDA, which is a continuous throughout systole and diastole. It is often an S2 heart sound which is difficult to detect, and the murmur begins just after S1 and crescendos peaking at S2 and then decrescendos to S1. So let's hear it how it is heard on auscultation. Now, in dynamic auscultation of the heart murmurs, it is actually referring to the maneuvers to alter the hemodynamic parameters during the cardiac auscultation in order to diagnose the etiology of a heart sound or a murmur. Now, one of this maneuver is known as the Valsalva maneuver, which is performed by having a patient bear down as if they are going to have a bowel movement, exhaling forcefully with airway closed. And the hemodynamic changes that occur are complex, however, the ultimate result is a decreased left ventricular preload. And the most important use of this Valsalva maneuver is to distinguish the murmur of the aortic stenosis from hypertrophic obstructive cardiomyopathy, or simply to bring the murmur of the hypertrophic obstructive cardiomyopathy or HUCM to be brought forward. In aortic stenosis, it will be softened and will not change, whereas in the murmur of HUCM, it will become quite loud with Valsalva. Now, the Valsalva maneuver is also performed during a routine echocardiographic examination to see if a patient with grade 2 or worse diastolic function can have a decrease his or her left ventricular filling pressure adequately. And if the Valsalva maneuver fails to reduce the left ventricular pressure in the setting of the diastolic heart failure, then grade 4 diastolic function is said to be present, indicating a poor diagnosis. Now the other maneuver is squatting. Now in squatting, it is a form of a standing position that forces the blood volume that was stored in the legs to return to the heart, which will be increasing the preload and thus increasing left ventricular filling. And this maneuver will decrease the murmur of Hookham, as the increased left ventricular volume helps displace the hypertrophied interventricular septum, causing less outflow tract obstruction. Now this maneuver causes the click of mitral valve prolapse to move later in systole. Now while standing from a squatting position, it causes quickly from a squatting position causes blood to move from central body to the legs, resulting in less blood returning to the heart and decreasing left ventricular preload. It is similar to the effect seen in the Valsalva maneuver. This maneuver will increase the murmur of Hookham and decrease the murmur of aortic stenosis. This maneuver also causes the click of mitral valve prolapse to move earlier in the systole. Now in passive leg raising, which is done simply by raising the legs high in the patient lying supine, and this results in blood that was pooled in the legs returning to the heart, increasing the left ventricular filling and preload. It is similar to the effect seen with squatting from standing position. Now this maneuver will decrease the murmur of Hookham, as the increased left ventricular volume helps displace the hypertrophic interventricular septum, causing less outflow tract obstruction. This maneuver causes the click of mitral valve prolapse to move later in systole. Now there is also a hand grip exercise, also known as isometric hand grip exercises, which are performed by having patients squeeze hard repetitively. This results in increased blood pressure similar to exercise and thus increased afterload. Elderly individuals may have a hard time with this maneuver, and transient arterial occlusion can be used instead. Now this maneuver will increase the intensity of the left-sided regurgitation murmurs, including mitral regurg and aortic regurg. However, the hand grip exercise will have no effect on the murmur of the atrial stenosis, which helps distinguish the presence of the coexistent mitral regurg from the Galliverdin phenomena. Now, the Galliverdin phenomena is a clinical sign found in patients with aortic stenosis, and it is described as dissociation between the noisy and the musical component of the systolic murmur heard in the aortic stenosis. And one more thing that we do is amyl nitrate inhalation. It decreases the left ventricular afterload by dilating the peripheral arteries and would decrease the murmur of the mitral regurg. However, afterload is decreased and there is less resistance to the blood flow from the left ventricle through the aortic valve. This means less blood regurgitates through the mitral valve and thereby decreasing the intensity of the murmur. Now, amyl nitrate can be given via inhalation to reduce the afterload for diagnostic purposes, and in cardiac catheterization laboratory to invoke left ventricular outflow tract gradient in patients with Hookham or a hypertrophic obstructive cardiomyopathy, or as a diagnostic tool during the cardiac physical examination. Due to the advancement in echocardiography, it is not commonly used any longer. So this was all about the heart sounds and murmurs. Hopefully will be helpful for you to understanding on the subject. Do like and subscribe if you like it. Take care and goodbye.